outward current. هلا it depends on the mutation. إذا كانت gain of function يعني بيزيد الاكشن تاع الشانلز، بيزيد الاوبننج، فبيزيد مثلا الصوديوم انتري، او mutation resulted in a loss of function of that ion. مثلا في potassium channels قل عندي الفانكشن تاعها، بطلت تطلع بوتاسيوم لبرا which led to decreased outward current. GF gain of function يعني the mutation resulted in a gain of function of that protein، ولا F loss of function of that protein. It can relate to any form of mutation مش فقط يعني بهذا المرض. هذا المصطلح يعني بنستعمل كل انواع الميوتيشنز. الجين اوف فانكشن زاد الاوبننج تاع الصوديوم شانل فور اكزامبل، زاد الابستروك ليفل، فبتزيد الشانس اوف اريثميا in those individuals. هلا في two tables، في كثير tables بالكتاب. This is the molecular and genetic basis of some cardiac arrhythmias. We're not gonna of course memorize any of it, but high different ion channels or proteins that can be affected, which gene is defective in those mutations, should chromosome عليهم, which should resultant kind of function, either loss of function or gain of function. هلا في other mutations أو genetic conditions غير الترسادي بوينتر ما يعني مو مطلوبين منكم يعني next two slides هذولا. other congenital arrhythmias اللي هم examples عن mutations بصيروا channels ثانية. في عندي short QT syndrome بصير عندي gain of function mutation potassium channel، catecholamine polymorphic ventricular tachycardia بتصير بالcalcium channel أو بشيء اسمه الريونايد receptor. في عندي sick sinus syndrome, Brugada syndrome and familial atrial fibrillation. فمو مطلوب منكم تعرفوا هاي congenital arrhythmias for the exam purpose. هو مطلوبين منكم حيمروا عليكم يعني إن شاء الله during your careers، بس أنا ما حسألكم عن هذا الموضوع، بدي أركز أكثر على الأدوية. في حدا عنده سؤال؟ هلا الترسادي بوينت حكينا it is caused by a mutation or other conditions. What other conditions precipitate for this important? ليش كثير احنا بنركز عليها؟ لأنها it can happen and it can be lethal in the individual, so it's very important to try to differentiate it. The risk factor we have bradycardia, hypokalemia يعني نقص البوتاسيوم، فبتلاحظوا إنه بنتريت them we give them potassium. Triggered upstrokes and drugs that increase in action potential duration, say for example sodium channel blockers. So what is the treatment? We want to decrease the triggered upstrokes. We can use either beta blockers or magnesium. We want to decrease the action potential duration, and we can give potassium supplements. In addition to that, recently كتير في papers بالخمس سنين الماضية حكت قديش الفائدة اللي لاحظوها إنه if those mutations are identified, patients are put on a beta blocker, and this can help prevent the occurrence of Torsades point in susceptible individuals. Yes طبعا. احنا هلا حكينا التريتمنت بعد ما تصير الاتاك. هلا إذا صار عندي اتاك اوف كورس شو التريتمنت اللي بتعملهم؟ DC fibrillation، بس in addition to that بتعطيهم during their stay in the hospital هاي الاشياء to prevent the reoccurrence of an attack. نرجع لموضوع الميوتيشنز. which هلا kind of mutation لا حكيت بالنسبة للترسادي بوينتر هاي هلا gain of function of inward current channels يعني بتزيد التدخين أو loss of function of outward رح تمنع ال repolarization. Okay? Excellent. Yes, sure. هلا في كثير حكيت هم 300 جين بيصيروا ب different ion channels يعني. هلا كل واحدة من هاي الميوتيشنز اللي هي ممكن تصير، يعني مش الواحد بيكون عنده كل هاي الميوتيشن، ممكن تكون عنده one of these mutations. Some of these mutations cause loss of function, some of them cause gain of function. فمثلا this is a sodium channel. نلاحظ إنه mutation caused a gain of function here. شو يعني gain of function؟ It allowed more entry, more inward current. إذا كانت بجوز هاي yeah. So this is a potassium channel, صار عندي loss of function. فمنعت outward current. فقللت. Yes, those two events can cause arrhythmias. Yes. هلا ممكن تكون طبعا بيعتمد على الانديفيدوال، ممكن يكون عنده ميوتيشن واحده، ممكن يكون عنده اكثر من ميوتيشن، بس زي ما حكيت لكم الميوتيشنز عديده. شو يعني 300 يعني ممكن يكونوا باماكن مختلفه من الجين يؤدوا لهذا البروتين الديسفانكشنال. ليش؟ اللي هو mainly بصير مو برضه repolarization. اللي هو mainly potassium current. بس it can occur both during plateau or during repolarization. هلا بيعتمد على channel. Which channel is involved in each state. فبيعتمد الميوتيشن صارت بأي channel. عرفت؟ يعني لو نرجع هي لأني أنا صراحة مو حافظة كل ما عندنا ولا صورة. Different kind of channels that are responsible. يعني مثلا هنا هاي الريكتيفاير هاي بالاس اي نود المسؤولة عن repolarization. فلو كانت الميوتيشن هنا رح تأثر على هاي المرحلة من الأكشن potential. هلا هي I didn't put the kind of potassium channel. But depending on the kind of potassium channel, whether a mutation occurs of it, it's going to affect that part of the action potential. Okay? بتلاحظوا لو طلع الجدول هذا في different kind of potassium. هي واحدة وأنا مش حافظة أنواعهم كلهم يعني this is rectifier. هي another one. هي another one. So it can happen in either of these channels. بس لاحظوا كمان بعض البوتاسيوم channels صار loss of function, بعضهم صار gain of function. So it's going to have a different effect. So I'm going to all of these mutation cause the Torsades point. No, these mutations are associated with different kinds of cardiac arrhythmias. مش كل هاي الميوتيشنز اللي موجودة بهذا الجدول مسؤولة عن المرض اللي حكينا اللي هو Torsades point. لأنه لو تلاحظوا السلايدين اللي بعد اللي قلت لكم مو مطلوبين برضو في ميوتيشنز بيعملوا أمراض مختلفة أخرى. So what is the treatment? إحنا عندنا two forms of treatment, either pharmacological, which is going to be the focus of our topic أو our يعني interest أكثر لهاي المادة. في عندنا non-pharmacological therapy. يعني ممكن arrhythmias can be treated. Sometimes we have to intervene and perform a surgery. Sometimes we do a radiofrequency catheter ablation. شو معنى هذا الحكي؟ بدخلوا electrode from one of the blood vessels أو vein, mainly in the groin region. بدخلوه بيوصل للقلب. هذا الالكترود بيعمل detection للأكشن potential ب different points of the heart. بيحدد لي، أنا غالبا بكون من الساينز symptoms عارفة تقريبا وين المنطقة. بيحدد لي وين عندي الاريا of the arrhythmia. بعملها radio frequency يعني زي حرق بالليزر شبيه فيه. فبقيم هاي المنطقة. So we remove this area or we do it by cryo ablation يعني by تبريد أو التجميد لهاي المنطقة. Yes. Another method اللي هي non-pharmacological اللي هو defibrillator بس مش الخارجي. في ناس لازم نزرع لهم implantable cardioverter defibrillator. Another method هي hopefully it's going to go in practice soon اللي هو الجين ثيرابي. ليه؟ لأنه حكينا قديش في mutations. حكينا 300 mutations are responsible. So if we can either correct that mutation by giving the correct gene, correct sequence, we can fix the arrhythmia from the source of the dysfunction. So what are we going to talk about today? We're going to talk about anti-arrhythmic drugs. How do anti-arrhythmic drugs work? They can affect two things, either the automaticity. So the drugs that affect automaticity or drugs that affect the conduction abnormalities. Most of the antiarrhythmic agents suppress automaticity by blocking either sodium or calcium channel to reduce the ratio of these ions to potassium. ذاكرين انه الفاني كرنت mainly حكينا هو صوديوم اللي هو مسؤول عن leakage، بس برضه حكيت في involvement also for the calcium in that leakage اللي هو phase 4 of the action potential that is present in the SA node or any organ any يعني point كله بالقلب any tissue that has triggered automaticity. I can suppress that by suppressing sodium or calcium channels. So this will result in reduction of depolarization of diastolic and raises the threshold of discharge to a less negative voltage. هلا في أدوية بتشتغل على conduction abnormality اللي هي حكينا mainly re-entry if you remember paroxysmal atrial tachycardia. So these can help in prevent re-entry by slowing the conduction or increasing the refractory period. Yes. هلا احنا بنحكي عن tachycardia بهاي الحالة in particular اللي هي paroxysmal ventricular paroxysmal atrial tachycardia. هلا بحالة البراديكارديا of course the treatment will be different، بس أغلب أنواع الأريثمياز that we are mentioning here they are associated with increase of the rate. I think this slide we talked about a little bit last time. We said the available anti-arrhythmic drugs suppress the arrhythmias by blocking the flow through specific ion channels or by altering the autonomic function. And we're going to be categorizing these anti-arrhythmic drugs into 4 categories. According to what I just said, شو بتتخيلوا هاي 4 categories? They're going to interfere with 4 things. Channels, شو هم الchannels? Sodium, calcium, or potassium. And the 4th category اللي هو autonomic function. So we have 4 classes, class 1, 2, 3, and 4. We're going to be detailing the different drugs that belong to each class. Yeah. ايه هو؟ هو له خاص بالفيجاس نيرف، بس احنا ما بنشتغل بالفيجاس نيرف، بنشتغل على البيتا ريسبتورز اللي هم البيتا بلوكرز. هلا بس ممكن if you wanna stimulate the vagus nerve yes this can work يعني ممكن تكون نحكي remedy for the treatment of a cardiac arrhythmia. واحد حس حاله عنده arrhythmia يحاول يعمل مساج وسيميليت vagus nerve، هذا بيقلل، وهي إحدى الطرق إذا لا سمح الله حدا صابه tachycardia for any reason. He one form of arrhythmia is to try to massage an area in the neck that will stimulate the vagus nerve. Okay? But pharmacologically we do not we mainly يعني هلا ممكن إحنا نستعمل atropine for example، بس مش atropine specifically يعني any drug that modulates parasympathetic nervous system، بس بنفضل احنا الدايركت افكت على الريسبتور الموجود بالقلب اللي هو البيتا 1 receptor. فايتس better to use a beta blocker for this treatment. Okay, anti-arrhythmic drugs might help control arrhythmias but unfortunately they might cause them too. فراح تلاحظوا هلا لما بلش اعرض بالادويه كل دواء من السايد افكتس تاعته راح تلاحظوا انه it can cause different kinds of arrhythmia. هلا what is the role شو الكلمة الأولى؟ ولا مو باينة معكم؟ رول مش عاجبني الجملة يعني من ناحية grammatical role of mechanism of action. Anyway, the role of principle of mechanism of action of anti-arrhythmic agents. حكينا mainly anti-arrhythmic drugs they like or most of them they like to bind to the channels either in the activated or inactivated state and less so in the rested state. So they are use dependent or state dependent. نطلق عليهم هاي الكلمة. In addition to that, they have selectivity and differences in their kinetics of binding. يعني بعضهم بيرتبطوا بالchannels quickly and they get removed from them quickly, which will affect their effect على الأكشن potential. The channels in normal cells will usually rapidly lose the drug from the receptor during the resting portion of the cycle. هلا هاي الselectivity إنه هم بفضلوا activated versus resting. It is lost with increasing doses. عشان هيك بنبلش نشوف إحنا arrhythmias when we use an overdose of an anti-arrhythmic agent إنه رح يبطل بس يشتغل على activated channel. It will also affect the resting or normal channels. So these drugs become pro-arrhythmic, arrhythmic صح. مرات بحكي arrhythmic مرات arrhythmic. And both of them are synonymous. During fast heart rates, acidosis, hyperkalemia or ischemia. Yes, they can. Especially إذا كان عندي another cardiac condition. فرح تلاحظوا إنه في مثلاً بعض الأدوية they are only used in normal hearts. Others are also safe to use when we have an ischemic disease, for example. وبرضه بتعتمد على الدوز of the patient. وبتعتمد كتير على electrolyte balance, على potassium and sodium levels. So this is the summary of the categories. حكينا هم 1, 2, 3 and 4. So 1 هدول 3 subcategories of 1. They are mainly sodium channel blockers. 2 is the beta adrenergic blockers, اللي هم they modulate the autonomic nervous system. 3 potassium channel blockers, and finally 4 هم calcium channel blockers. Again, this is a summary of what I just said. Class 1 drugs is sodium channel blockers. The subclasses of this هم class 1A, class 1B and class 1C بيفرجوني التغييرات اللي بتصير على الاكشن بوتنشال ديوريشن. هلا حتلاحظوا خلال السلايدات حكي لكم تغييرات بتصير على الاكشن بوتنشال ديوريشن على different phases of the ECG. يعني شو الافكت على QRS interval, شو the effect على waves, different waves. أنا ما بدي أطلب منكم تغييرات دقيقة على ECG. What I want you to focus on عشان يعني كثير رح يصير الموضوع صعب عليكم تحفظوهم كلهم. اللي بدنا إياه نركز عليه اللي هم changes على action potential duration على refractory period with regards to the different drugs. So حكينا 1B, 1A, 1B, 1C they differ in their effect on the action potential duration. Mainly 1A they prolong the action potential duration. 1B shorten the action potential duration. 1C does not have a lot of effect. بنحكيها none تقريبا. هلا another difference اللي هي kinetics of their dissociation or association. So class 1A dissociate in an intermediate kinetics, يعني سرعة فصل الدواء عن الchannel. Class 1B it is a rapid kinetics, while class 1C shows slow kinetics. So if I want to just show this picture, this is showing us the difference of the effects of class 1 anti-arrhythmic drugs on action potential duration. فبنلاحظ إنه class 1A it increases it, class 1B it decreases it, and class 1C does not have a lot of change. هلا other effects حكينا عن ECG ما بدنا نطلب منكم تحفظوها حاليا. Probably through practice لما تبلشوا تتعلموا يعني العملي تاع قراءة ال ECG you're gonna be able to detect these changes better. Other repetition here, classification of anti-arrhythmic drugs. حكينا class 2 anti-arrhythmic sympatholytics اللي هم they are mainly the drugs that reduce the beta adrenergic activity. Class 3 اللي هي drugs that work على delayed rectifier potassium current. فهم بيقللوا repolarization إنه يصير بيزيدوا plateau phase. So what's the effect on the action potential duration? They're going to increase it. Finally, class 4 اللي هم calcium channel blockers. Mainly this work on the conduction. So the action slows the conduction region where the action potential is disrupted, or the conduction is disrupted. And remember, upstroke is calcium dependent. Where is that?
The action potential تبع النود.
Excellent. The action potential تاع النود, the upstroke, it's mainly calcium entry. So these drugs also might be beneficial in controlling, increasing or decreasing the upstroke. In this case, usually we decrease it. We want to decrease tachycardia or the rate. Okay, now, all of these drugs probably we didn't mention it yet كانت السلايد اللي قبل. While they are حكينا mainly sodium channel blockers or potassium channel blockers or calcium channel blockers, they have mixed actions. فهذا التيبل شوية صعب ما حنحفظه at all. فيه بقول لك what are the different channels. So this is the ability for a particular drug to block sodium channel. This is the calcium channel blockage, and I think that's it here. Yeah, their effect on the pacemaker activity, their effect on the sympathetic nervous system or sympatholytic action. فبنلاحظ إنه بعض الأدوية yes they have effects mainly مثلا amiodarone. It has effects on sodium channels. It also have effects on calcium channels, but their effects are different on these channels. What else here? Yeah, it has also some effect on the sympathetic action. هلا احنا ما بدنا نحفظ هذا الجدول at all. مع انه موجود بكتابكم بس شوفوا قد ايه انا بحاول اخفف عليكم. ما بدنا نحفظ جداول. في كثير جداول.
دكتورة مش اميدرون عبارة عن كلاس 3، طب شو دخل بالصوديوم؟ المفروض بوتاسيوم.
مين اللي سأل السؤال؟
أنا.
صح. هاي النقطة اللي حكيت لكم إياها قبل شوي. خليني أعيد to re-emphasize. بجوز النقطة مش واضحة. I'm kidding with you. ما بطلب تحفظوا الجداول. لخصت لكم النقاط من كل جدول اللي بدي إياكم تعرفوها. هلا بسأل زميلكم الأميودارون هو mainly class 3. فهو المفروض يشتغل على البوتاسيوم على الكالسيوم بوتاسيوم ليه له افكتس على الصوديوم وليه له افكت على الكالسيوم. زي ما حكيت لكم كلها مو كل الادويه، بعض هاي الادويه هي موجوده بالجدول لها افكتس على other kind of channels. بس المين افكت اللي احنا شايفينه اللي عم يعطيني بنفيت اللي هو على الشانل اللي تصنف من ضمنها. عشان هيك هو فائده هذا الجدول بقول لك شو ال other channels that can be affected by these drugs. ومش بس ال channels، حكينا other activities زي sympathetic activity. بس الإفكت على الأكشن potential duration. لا ما تحفظهم يعني اعرفوهم اذا بدكم بس يعني ما حسألكم عنهم في الوقت. يعني هلا هذا تيبل ثاني برضه بيعطيني information. شو information؟ Information is more useful in this table for us as physicians. انه احنا بنعرف شو نختار دواء لكل مرض او كل نوع من انواع الارثميا اللي حكيناها. So these are the clinical pharmacological properties of anti-arrhythmic drugs. For example, هلا لاحظوا الادينوسين what kind of tachycardias or arrhythmia does it treat? It can cause a very good effect on supraventricular arrhythmia. فهذا السؤال دائما بيجي بالامتحانات. What is the drug of choice for the treatment of supraventricular arrhythmia? The answer is adenosine. ليه؟ لأنه لاحظوا هو له أكثر effect عندي 4 pluses أو 5 pluses 4. ventricular questionable effect تاعه مثلا. And this applies for all of these. كل واحد حكينا احنا قديش فاعليته بعلاج supraventricular اللي هي atrial وقديش فاعليته في علاج الventricular. So I'm not going to ask you to memorize it, and if you don't want to go through it at all, it's okay because all the information will be repeated when we mention each of these drugs individually. الادينوسين لسه ما حكينا عنه. We're going to talk about it later on. هلا انه mechanism of action تاع الادينوسين it's separate than the 4 drugs, the 4 classes of drugs that we mentioned. يعني مع انه انا حكيت فيه عندي 4 classes اللي هم 1 2 3 and 4 بس في عندي other drugs that are not classified. They are not classified by the system. هذا السيستم اسمه Vaughan-Williams classification. الإكزامبل على هاي non classified اللي هو adenosine, digoxin and magnesium chloride. So let's start talking about the drugs. The first group اللي هم class 1. Class 1 كيف بيشتغلوا؟ probably هذا حفظناه يعني سؤال سهل. Sodium channel. حكينا في عندي 1A, 1B, 1C. one example أو the prototype of 1A اللي هو quinidine. Quinidine كتير similar to the structure of quinine. هو an anti-what? Anti-malarial drug. So it comes from a natural source اللي هي cinchona tree. حكينا it has antipyretic action, it has anti-malarial effect. الeffect تاعه اللي هو sodium channel blockers, but it also can inhibit alpha and muscarinic receptor. هلا بما انه بيشتغل على sodium channel، لو نحكي عن normal myocardium it's gonna affect the upstroke. So it's gonna slow the upstroke. It's gonna also slow the conduction, which will result in prolongation of the action potential duration and the QRS duration. اللي هو I told you we're not gonna be worried about, but other effects. How does it work? It works by binding to sodium channel, preventing sodium influx, so slower the rapid depolarization. It inhibits arrhythmia, which can be caused by increased automaticity, and it's also beneficial or helpful in re-entry arrhythmia. عشان هيك حكينا هو يستعمل كمان بالconduction problem. Nowadays, it's only used to treat normal heart. Why? Because it's been found إنه ما بنقدر نستعمله بالناس اللي عندهم مثلا history of myocardial infarction أو other diseases زي ischemia أو heart failure. ليه؟ لأنه ممكن يعمل provoke للأريثميا عندهم. So what kind of arrhythmia? It's used to treat atrial or ventricular arrhythmias in patients who have normal heart. This is its indication. What are the side effects? It can cause GI side effects such as nausea and vomiting. نسبة عالية جدا 18 ل 33% من individuals. It can cause headache, dizziness, tinnitus, hypersensitivity reaction, thrombocytopenia, excessive prolongation of the QT interval. شو معنى هذا؟ لما نحكي excessive شو excessive QT suicidal so it can predispose to suicidal ممكن يعمل slowing the conduction, hypotension, or serum digoxin level, warfarin level will be increased. Why do you think that? Excellent, excellent. So I want you to remember this, to go back to your information about drug-drug interaction. لأنه كتير خطيرة drug interaction بالأريثمياز. Digoxin is a very serious drug. Why is digoxin very serious? شو حكينا في شيء؟ Excellent. It has a narrow therapeutic window أو low therapeutic index. بالتالي أي تغييرات فيه بتؤدي للتوكسيسيتي. وحنحكي احنا عن digoxin كتير بحضرة الهارت failure. As I told you, we don't use it nowadays so much because of its toxicity. بس في sometimes indication for it use. وفي لساتها دول يعني ممكن تروحوا مثلا تشتغلوا مناطق نائية، دول أفريقية مثلا، تلاحظوا إنه لسه هاي الأدوية القديمة لساتها تستخدم because this is what they have available. So you need to know all of the نحكي pharmacodynamics related to these compounds. So one important thing with regards to drug-drug interaction، أول إشي لما يكون الدواء عنده زي digoxin narrow therapeutic index هذا بيزيد الخطورة. برضه الورفرين عنده narrow therapeutic index. إذا زاد الليفل تاع الورفرين شو بصير عندنا؟ bleeding which can be fatal. هلا إحدى الأشياء شو اسمك؟ محمد اللي ذكرها محمد، وهي مهمة، مكان جدا شهير للتداخلات الدوائية هو major site drug-drug interaction. أو we have two major sites اللي هو cytochrome P450. What is that? Do you remember? Yeah, اللي هو it's responsible for the metabolism of drugs اللي هو phase 1. So what happens إنه إذا افترضنا إنه metabolism the purpose of it is to convert the drug from the active form to the inactive form. If you mess with this pathway, you prevent the metabolism, you're going to increase the active form, so you're going to increase the effect of the drug. Increasing the effect of the drug while it might be beneficial is going to increase the toxicity of the drug. لأنه احنا مو حاسبين حساب إنه يضل في جسمنا هاي الكمية من الدواء، احنا حاسبين حساب الكمية الأقل بدون هذا التداخل الدوائي. The second site of drug-drug interaction شو هو؟ Yes, excellent. برضه هون حكوا I think حكوا distribution والbumin اللي هو during the distribution the drugs that like to bind to plasma protein. فبرضه digoxin والquinidine I think this was an example دكتور يعقوب's سلايد لاست يير جاب لكم اكزامبل كوينيدين. يعني كان مريض ماخذ ديجوكسين وجينا اعطيناه كوينيدين، ايش الكوينيدين برضه بحب يرتبط بالالبوم. It kicks out digoxin from the binding site, so the levels of digoxin are going to increase, and the same applies for warfarin. يعني مريض بياخذ warfarin مميع، يجينا اعطيناه كوينيدين، كوينيدين طرد الورفرين from the plasma protein binding site، زاد الورفرين، يزيد التندنسي of bleeding in the patient. حكينا الكوينيدين we don't like to use it in patients who have other cardiac condition because it has been associated with sudden death. عشان هيك كثير استعماله قل in patients who have concomitant heart diseases. Now the next drug اللي هو procainamide. Procainamide is a drug that can be given either orally, IV or IM. Can be given orally, but the problem it has a short half-life. فيعني we don't use it for patients we want to give them once a day, for example. So this is a problem. يكون short half-life, the patient has to take multiple doses or multiple times the drug. هلا very important thing، وهاي الاشياء اللي بسأل عنها بالامتحان. What is the side effect associated with procainamide؟ هاي السلايد الأولى فيها الاشياء الواضحة عنه. It is associated with symptoms similar to LE. شو LE؟ Lupus erythematosus. Excellent. اللي هو you know lupus erythematosus, right? It's an autoimmune disease that's happening mainly بالmucocutaneous membrane, but it also affects the radicular endothelial system, can cause damage to the spleen and the liver. It's a kind of systemic lupus erythematosus. هلا this drug in 30% of patients صار عندهم signs شبيهة باللوبس erythematosus, probably mucocutaneous, not systematic. Other things related to procainamide that are special إنه لما يصير له acetylation it produces something called NAPA اللي هي مكتوبة بعدين نسيت stands for what. I don't know. إيش procainamide? N-acetylated procainamide, yeah, probably. So N-acetylated procainamide has class 3 actions. يعني metabolites of this drug will affect potassium channels. Another drug related to procainamide is called disopyramide. أنا ما حشرح عنه كتير. This is another example of class 1A anti-arrhythmias drugs. More information about procainamide. What does it do? The major electrophysiological effects. حكينا it is affecting sodium channel. So it is structurally related to the local anesthetic procaine. نعرف احنا لما نروح نخلع سن مثلا عشان بيخدروا سننا نستعمل local anesthetic. Local anesthetics are drugs that interfere with sodium ion channels as well. One of these local anesthetics is called procaine, another one called lidocaine. So I want you to remember, whether you are a patient or you are a doctor, that all of the local anesthetics that are used, they have the potential to cause arrhythmia if they get absorbed to the systemic circulation. Why we don't worry about that so much? لأنه we're giving them locally. So مثلا في حالة dental procedure أو let's say you have a patient who have an injury بدك تعمل له minor surgery على الهاند بدك تعمل له local anesthesia, you're giving the drug in that localized area, so you wouldn't worry about systemic absorption. But we remember from pharmacokinetic last year, because some systemic absorption will happen. So we have to be careful. We have to take very good history of the patient. If they have a history of cardiac arrhythmia, if they take anti-arrhythmic drugs, because this drug will interfere with the heart. عشان هيك if you remember, when do they add to the local anesthetic bottle? Epinephrine, excellent. Why is that? Vasoconstrictor, yes, you are right. شو هدف الفازوكونستريكتور أو الإبنفرين؟ Yes. مين عم يحكي هون؟ ضل باللوكال اريا كمان.
بقلل الابسوربشن.
بقلل الابسوربشن، ممتاز تماما. شو يعني ابسوربشن؟ بقلل الديستريبيوشن، systemic absorption. احنا يعني this is we don't want it to get to the rest of the body. We want it to stay localized. في شيء ثاني بيزيدوا الابنفرين. يعني هاي هيك معلومة ما لها علاقة بهذا. قلل البليدنج، excellent. لأنه بيعمل vasoconstriction. نرجع هلا لموضوع الاريثمياز والبروكانامايد. The major electrophysiological effect, it decreases automaticity. كان لانه بأثر على الصوديوم شانل فرح يأثر على الفيز 4 spontaneous depolarization بالاس اي نود او بالاي في نود. It decreases conduction velocity throughout the heart because it decreases membrane responsiveness. يقلل الفي ماكس تاعت الشانلز. Also حكينا it increases the action potential duration and refractory period in both the atrial and ventricular cells, which can cause blocking of the potassium efflux. So this is in summary. هذا بدي اياكم تعرفوا بس ما بدي اياكم تعرفوا the rest of the ECG changes انه هو بيزيد ال action potential duration, effective refractory period وبيرفع the threshold. Another drug that is a class 1 but this one is class 1B. شو حكينا الفرق؟ class 1A increases refractory period, class 1B decreases. Sorry, class 1A increase or prolong the action potential duration. Class 1B they decrease it. Why is that? They have higher affinity to bind with the activated and inactivated sodium channel with rapid kinetics. Because of the rapid kinetics ما بيلحقوا كتير to prolong the action potential duration. They also act selectively in ischemic ventricular tissue to promote conduction and block free entry. What do I mean by that? Remember when we talked about the unilateral block last time? So we said alpha arm and beta arm. You remember these two concepts? So the alpha arm is the slower and the beta arm will go around, and because it has a shorter refractory period, it's going to be activating it. Both of these drugs, class 1A and class 1B, can help in the re-entry in هم بيمنعوا الconduction تاع البيتا arm, so it's not going to be able to reach the blocked area in a time to be able to activate the re-entry أو cycle مرة تانية. What happens is because it's going to slow down the blocked area, they're going to meet in the middle and counteract the effect of each other. فما بصير في عندي circuit. هذا بنسميه bi-directional block. So the two arms, الألفا والبيتا, they meet in the same time, at the same intensity. They antagonize each other or counteract each other, resulting in the use of sodium channel blockers for the treatment of re-entry blocks. They are more effective when we supplement with potassium, and they are not very effective in atrial arrhythmia. Mainly هو used to promote conduction and help in the treatment of block re-entry. الكاينetics ما بدي اياكم تحفظوها كثير الا الاشياء المميزه، يعني مثلا حيمر علينا مثلا as well absorbed ineffective orally due to first pass effect. This is very important. Why is lidocaine only given IV? Because it gets subjected to the first pass effect. It gets well distributed including the brain. فبالتالي هذا مسؤول عن central nervous system side effect. It causes paresthesia, tremor, nausea, slurred speech, and convulsions. Yes, it does cross the blood-brain barrier. Excellent. It is the least cardiotoxic of the class, except for hypertension with high doses. ليه؟ لأنه بيعمل depression of the myocardium. بقلل الميوكارديوم من ضخ الدم فبصير عندي hypertension. But it is the least cardiotoxic. It was used to treat all myocardial infarction patients to prevent the appearance of ventricular arrhythmia. So this is one indication, one important indication for its use. هلا أدوية أحسن. ليه حكيت was routine use؟ لأنه في أدوية better that are used to treat ventricular arrhythmias, but it's still a good therapy for that condition. Tocanide and mixilitine, هذول other examples of class 1B drugs. Both of them are analogues of lidocaine. What do I mean analog? Yani it's similar to lidocaine in all of the effects that we just mentioned. The difference between them, these are orally available, so they can be used orally. Another difference is side effects. Tocanide can cause blood dyscrasia, for example. Mixilitine is associated with more neurological side effects. Another drug اسمه phenytoin. Phenytoin is mainly an anti-epileptic agent. But كيف هو بيشتغل as an anti-epileptic agent? It blocks sodium channels. So also it's been shown to be useful to treat certain kinds of arrhythmias. Example are these kinds. ممكن أسألكم what is the drug that from these group that is useful for the treatment of digitalis-induced arrhythmias? The answer would be phenytoin. شو يعني digitalis-induced arrhythmias? Digoxin or digitalis, it's a drug that's used to treat arrhythmia, that's used to treat heart failure, but it is pro-arrhythmic, so it can cause arrhythmia to a higher degree, يعني أكثر من باقي anti-arrhythmic drugs. عشان هيك we don't use it nowadays so much. So phenytoin is useful for this kind of arrhythmia, and the other drugs we're going to talk about as well. Digoxin هو نفسه digitalis, يعني different chemical compound بس كلهم الاثنين نفس exact mechanism of action. Arrhythmias after congenital heart surgery, also it's indicated for this kind of arrhythmia. So phenytoin is used to treat arrhythmia after congenital heart surgery and to treat congenital prolonged QT interval. Class 1C, حكينا شو الفرق بين class 1C والباقيين؟ ما لها effect كثير على action potential duration. هلا why is that? The drug here is called flecainide. It's a potent blocker of sodium and potassium channel. But in addition, for its effect on sodium channel, also it can block potassium channel. So it can cause negative inotropic effect. It is pro-arrhythmic, كلهم pro-arrhythmic, so it can increase ventricular tachycardia. It's effective in supraventricular tachycardia in the normal heart. Yes, it is a blocker of sodium. Yes, channel inotropy, it blocks conduction, yes. Chronotropy or inotropy, yes. Let's talk about the general properties. It has marked affinity for mainly sodium channel. It causes marked slowing of conduction of velocity. This can lead to a shallow phase zero slope. It does not have a lot of change on action potential duration. It's useful to treat resistant life-threatening ventricular arrhythmias. Toxicities, it is pro-arrhythmic, especially in patients who have myocardial infarction. It can cause blurred vision and central nervous system side effects, but also it is pro-arrhythmic, فممكن يسبب ventricular arrhythmias and sudden death. هو mainly the supraventricular, but it also can be used in ventricular arrhythmias in patients who have myocardial infarction. Sorry, it is pro-arrhythmic in myocardial infarction. So it is only useful in resistant life-threatening ventricular arrhythmias, يعني resistant that are not responding to any other treatment. Yes. في أدوية أحسن منه. إذا المريض ما استجاب لأي شيء ثاني, we go ahead and use flecainide. ليه؟ لأنه هو ممكن يسبب ventricular arrhythmias. Are we done with the time?
yes.
اوكي، معلش تتذكروا لي وين وصلنا بالسلايدات؟